I'm Dr Katherine Hickman, a GP in Bradford and current respiratory lead for West Yorkshire ICB. I'm going to be discussing how to improve asthma diagnosis in practice. Asthma is the most common respiratory condition, primarily driven by inflammation of the airways. As shown in the diagram, the lining of the airway in an asthmatic bronchiole is inflamed compared to a normal bronchiole. This inflammation results in excess mucus production and narrowing of the airways. Additionally, the smooth muscles surrounding the bronchi become hyperresponsive, leading to spasms when exposed to triggers. These changes collectively cause the classic symptoms of asthma, including wheezing, coughing, chest tightness, and shortness of breath. Asthma symptoms can be triggered by various factors such as allergens, exercise, respiratory infections, or environmental irritants, with severity varying widely among individuals. Asthma can be challenging to diagnose due to its fluctuating nature. Symptoms such as wheezing, shortness of breath, chest tightness, and cough can vary in intensity and may not always be present during medical examinations. Additionally, patients may experience variable expiratory airflow limitation, making objective testing difficult. A key diagnostic clue is a history of symptom variability and identifiable triggers such as allergens, exercise, or respiratory infections. However, physical examination findings may be normal unless the patient is symptomatic at the time. The presence of an expiratory polyphonic wheeze can support the diagnosis, though it is not always detectable. Risk factors, including a personal or family history of atopy, such as eczema, allergic rhinitis, or asthma, further increase the likelihood of asthma. In cases where no clear alternative explanation exists for the symptoms, a clinical diagnosis of asthma becomes more probable. So what is the current situation? Asthma diagnosis presents significant challenges with both underdiagnosis and overdiagnosis being common. This can lead to patients not getting necessary treatment, leaving them at risk or being treated unnecessarily. Spirometry has been the primary confirmatory test, but long waiting times often delay diagnosis. Additionally, spirometry results can be normal, especially when symptoms are not present at the time of testing, making diagnosis more complex. In many cases, patients with suspected asthma have been started on short-acting beta agonists alone while awaiting spirometry, potentially delaying the introduction of anti-inflammatory treatment like inhaled corticosteroids. Another issue is the lack of standardization in coding and follow-up at the point of suspecting asthma. This variation can lead to inconsistencies in patient care and delays in receiving the appropriate treatment and monitoring. The latest guidelines emphasize that asthma is a clinical diagnosis, meaning that history and examination are crucial. Treatment should focus on the patient, not just test results. To aid diagnosis, markers of inflammation such as blood eosinophils and fractional exhaled nitric oxide or FeNO should be assessed. These help identify airway inflammation and guide management decisions. In preschool children under 5 years old, where diagnosing asthma can be particularly challenging, a trial of inhaled corticosteroids for 8 to 12 weeks is recommended. If a child has been admitted to the hospital or has had 2 or more A&E visits in 12 months, referral to a respiratory pediatrician is advised. To ensure appropriate monitoring and care, cases should be coded as suspected asthma where a firm diagnosis is not yet possible. Importantly, treatment should not be delayed in symptomatic patients. Waiting for a formal diagnosis can lead to unnecessary suffering and a risk of exacerbations. Once asthma is suspected based on history and symptoms, objective tests should be conducted as soon as possible to help confirm the diagnosis. However, no single test is definitive, so results may sometimes miss asthma, i.e. false negatives, or incorrectly suggest it, false positives. Instead, these tests form part of an overall clinical assessment supporting diagnosis alongside clinical judgment. So the key objective tests for asthma, so the primary tests are blood eosinophils, which is a marker of inflammation with a positive result typically above 0.4 to 0.5. FeNO measures eosinophilic inflammation even in asymptomatic patients, and a result of over 50 or equal to 50 parts per billion is considered positive. Spirometry with bronchodilator reversibility. This assesses airflow obstruction and response to bronchodilators. Greater than or equal to 12% and or greater than or equal to 200 mils improvement in FEV1 after bronchodilator administration suggests reversible airway obstruction characteristic of asthma. Peak flow variability involves measuring the peak expiratory flow twice daily for 2 weeks. A variability of greater than or equal to 20% supports an asthma diagnosis. It's useful for monitoring changes during acute asthma episodes and recovery. And finally, bronchial challenge testing, which is conducted in a hospital setting for cases where initial tests are inconclusive. It assesses airway hyperresponsiveness by exposing the patient to specific triggers. Asthma testing is not always conclusive, so clinical history remains central to diagnosis. These tests serve as tools to strengthen clinical suspicion, guide treatment decisions, and monitor disease progression. Diagnosing asthma in children and young people requires a structured approach using primary tests and, if necessary, additional testing to confirm the diagnosis. Primary tests are FeNO, a positive result being greater than or equal to 35 parts per billion, indicating eosinophilic airway inflammation. Spirometry with bronchodilator reversibility, a greater than or equal to 12% improvement in FEV1 supports an asthma diagnosis. Peak flow variability, if spirometry is unavailable, measuring peak expiratory flow twice daily can assess airflow obstruction. Additional testing, so skin prick testing in secondary care or total IgE, helps identify allergic triggers such as dust mites, pollen, or pet dander. Blood eosinophils, so a positive result is greater than or equal to 0.5, suggesting eosinophilic inflammation. If FeNO and spirometry results are inconclusive, both raised IgE and positive blood eosinophils are required to support an asthma diagnosis. Referral criteria, so if the diagnosis remains unclear after testing, refer to a specialist for further assessment. Diagnosing asthma in young children is more challenging due to limited availability and reliability of objective tests. Instead, diagnosis relies heavily on clinical history and response to treatment. Key diagnostic criteria includes a history of characteristic symptoms such as wheezing, breathlessness, cough, and chest tightness, response to an 8 to 12 week trial of inhaled corticosteroids, and improvement with treatment and worsening upon withdrawal strongly support an asthma diagnosis. So red flags for specialist referrals, so over 2 or more hospital admissions or emergency visits within 12 months, suggest severe or poorly controlled asthma and warrant referral to respiratory specialists. Key takeaway, asthma diagnosis in children requires a combination of history, primary objective tests, and response to treatment, with specialist referral if uncertainty remains. Asthma diagnosis is primarily clinical, requiring the integration of multiple pieces of evidence, similar to assembling a jigsaw puzzle. Because symptoms and test results can vary over time, a clear diagnosis may take months to establish. Code a suspected asthma. While awaiting confirmation, ensure the condition is coded correctly to facilitate follow-up and appropriate treatment. Explain the diagnosis to the patient. Use visual aids such as an airways diagram to help them understand why asthma is suspected. Discuss triggers, symptoms, and the need for further testing. Conduct available tests, so FeNO test if available at point of care to detect airway inflammation in both adults and children. Full blood count to check for eosinophilia, and review previous eosinophil counts if available. Peak expiratory flow rate, so measure in clinic and provide a peak expiratory flow rate meter for twice daily monitoring over 2 weeks. Even if not used for diagnosis, it can help with self-management. Start treatment, but never salbutamol alone. Prescribe an ICS formoterol inhaler as needed per updated guidelines. No patient with asthma or suspected asthma should be on salbutamol alone. Education and self-management plan, so teach proper inhaler technique to maximize effectiveness. Provide written guidance on managing an asthma attack and schedule a review appointment to assess test results and treatment response. Ensure follow-up, so implement a system for tracking patients who miss appointments or do not attend. Follow up to reassess and adjust treatment as needed. Key takeaway, asthma diagnosis requires a structured, stepwise approach using clinical judgment and objective tests where available. While awaiting full confirmation, patients should receive appropriate treatment, education, and follow-up to ensure optimal care. The quality improvement projects in this section of the toolkit will help you to think about whether there is potential for improvements in the process of making an asthma diagnosis in your practice. This includes coding, organising confirmatory tests, commencing initial treatment and follow-up. They also help you identify if there may be a cohort of patients who have attended with possible respiratory diagnosis in the past and been prescribed a salbutamol reliever inhaler who may need follow-up to confirm or refute a respiratory diagnosis. Thank you for listening.